Hey, hello everyone. Today we will be discussing regarding carcinoid tumor, and we'll get into the key insights of carcinoid tumor. And those who are live there, most welcome that you have taken out the time today, and you are there with all in Q&A. So you can ask any kind of a Q&A during the session, or um, at the end of the session, we'll be addressing all the questions. So carcinoid tumor is a very high-yield topic, as you all know. It is there in all kind of exams, USMLE, neetpg, PLAB, whatever it is for MBBS, MD, or those whatever who are pursuing the courses. It is very much important for to know the in depth of carcinoid tumor. So let's go into detail of carcinoid tumor. Let me start sharing the screen. Just a second. So hope you all are seeing my screen, carcinoid tumor. So we will be discussing regarding the carcinoid tumor. Yeah, so sorry for a little bit technical glitches. Now let's go directly to the carcinoid tumor. What is carcinoid tumor? Carcinoid tumor is a neuroendocrine tumor which is derived from enterochromaffin cell. So it is derived from enterochromaffin cells. It is also called as Kulczycki cells. So these are neuroendocrine tumors. There are many neuroendocrine tumors in the body, like small cell carcinoma of lung, even large cell carcinoma of lung. Many of other neuroendocrine tumors are there, and many other carcinomas are having additional neuroendocrine properties as well. So all of them, they have neurosecretory granules which are quite visible on electron microscopy, and they secrete many of the products. One of the most important one is the 5-hydroxytryptamine or serotonin, which has an important neurotransmitter in the both in the brain as well as in the gut. These carcinoid tumors generally have low metastatic potential. Most common site is gut, followed by lung, and other common sites are also there, but intestine is very common site. It is the most common malignant tumor of small intestine. There are various risk factors that increases the incidence of carcinoid tumor. Carcinoid tumor is more common in multiple endocrine neoplasia 1 syndrome, MEN1 syndrome. It is also commonly associated with NF1, neurofibromatosis type 1 syndrome, chronic atrophic gastritis, Zollinger-Ellison syndrome. These are all common associates. And they are all derived from APUD cells. What do you mean by APUD? Amine precursor uptake and decarboxylase cells. So these cells, they uptake the precursors of amine and decarboxylate them into mature amines. So that is APUD cells. So the different type of cells, the different locations of carcinoid tumors have different concentration of decarboxylating enzyme. That refers to the production of these mediators are basically how much ever is the decarboxylating enzyme, so how much they will produce that kind of neurotransmitters or amines. So amines, so what are the amines? The common amines are serotonin, they also can secrete ACTH and many other kind of a transmitters, many other kind of a substance. They can even secrete histamine as well, and prostaglandins as well. Common sites of carcinoid tumor include GI tract, as we mentioned already, bronchopulmonary system, some pancreas, adrenal gland, thyroid, carotid artery, ovary. So in these locations already there are neuroendocrine tumors which may have admixed carcinoid tumor features. This commonly occur in fifth to sixth decade. Gross appearance is yellow colored, and generally they are small and do not cause obstruction. If they are large, it may be polypoidal lesion and can cause obstruction. Cut surface is bright yellow in form, that is the identifying feature. Bronchial carcinoids may be located in the central bronchus, and it produces a collar button like lesion morphologically. Microscopically, the tumor cells are typically arranged in cords, trabeculae, sheets of cells, and they have the neuroendocrine property, the hyperchromatic cells with salt and pepper granular chromatin pattern is appreciated. Immunohistochemical markers are synaptophysin, chromoganin, S100, neuron-specific enolase. All these are there. So in your immunohistochemistry, you will always see these markers: chromogranin, synaptophysin, S100. These things will be noted in case of immunohistochemistry, which are seen in all kind of neuroendocrine tumors. So that we should look for, and apart from that, here you can see this, how does it appear. These are cells are quite monotonous looking, and they're having a granular chromatin pattern is being seen. I'll just increase the picture size. Here you can see the granular chromatin pattern, salt and pepper chromatin pattern is there, small stippled granules are there, which is quite evident, even can be diagnosed in electron microscopy as well. Grading, how do we grade the tumors? So it is well differentiated, moderately differentiated, poorly differentiated, cellular morphology, presence or absence of necrosis is taken into account. Mitotic count is very important. Chi67 index in immunohistochemistry is an indication of immunohisto is indicative of basically the mitotic potential. And size is very important. More than 2 centimeter are likely to metastasize, and there are two types of carcinoid based on the mitotic activities and necrosis. And the typical carcinoids are less than 2 centimeter, majority of the carcinoids, 2 mitosis per 10 high power field, and generally lack necrosis. Atypical or aggressive carcinoids are having more than 2 mitosis, generally 2 to 10 mitosis per high power field, and there will be necrosis, so much of pleomorphism. So generally, they are invading and metastasize to distant locations. So we discussed regarding the common site already. So the GI, what are the common sites? The ileum is the very common site. Apart from that, rectum, colorectum, stomach, and esophagus sometimes also may have carcinoid. Maybe they're in different portions, but generally these are the common site: ileum, appendix, colorectum, stomach. These are the common sites for the for this carcinoid tumor. So remember that carcinoid tumors are malignant and metastasize, and the metastatic potential, as we discussed, relates with the size and also with the location. Midgut carcinoids, based on the blood, based on their blood flow, and also they are more likely to invade and metastasize. So clinical behavior is largely determined by the exact location. Foregut and hindgut carcinoids generally rarely metastasize. They may invade locally, but metastasis potential is less. Clinical feature, many of the tumors produce the so-called carcinoid syndrome. So all the carcinoid tumors will not produce carcinoid syndromes. Majority of the carcinoid tumors, whatever the metabolites, whatever the amines they will be secreting, that will be basically deactivated by the first pass metabolism in the liver itself. So those who are basically metastasizing to the liver only, then they will bypass that first pass metabolism of liver. And those who only metastatic, it has been seen that only metastatic tumors, those who are metastasizing to the liver, they will only cause carcinoid syndrome features. They will be releasing lots of carcinoid tumor mediators into the bloodstream, and so because of the increased level of these mediators, so mediators are serotonin, ACTH, histamine, prostaglandin. They'll produce a plethora of symptoms like flushing, diarrhea, bronchospasm, GI distress. Then there may be a right heart failure because of fibrogenic potential of serotonin. It may cause endocardial fibrosis as well. 5-hydroxytryptamine and its products are largely elevated in urine, 5-hydroxyindole acetic acid, and they will be detected in the urine, and it is quite an important diagnostic marker for carcinoid tumor. So mid-gut carcinoids are more likely to produce because they have more of decarboxylatic enzyme. So they not only they metastasize, they also produce contents rich in the mediators. They will produce high level of mediators as well. And the common features include the common clinical features. Apart from the carcinoid syndrome, they can also physically cause bleeding, intestinal obstruction, cardiac complication. We discussed the fibrosis of the cardiac valve, endocardial destruction, hepatomegaly. It may cause whenever there is a liver metastasis. And the treatment, how to treat the patient: surgery, radiation, chemotherapy. You may give some somatostatin analogs. Some targeted therapies can also be given against the metabolites. So these are the overview of carcinoid tumor. So we discussed exact site, the ileum, the appendix, colorectum, bronchus. These are the common sites. We discussed the clinical features of carcinoid syndrome, bronchospasm, flushing, diarrhea, etc. And we discussed that they may cause obstruction as well, bleeding, intestinal obstruction, and cardiac complications, hepatomegaly are also there. The prime mediators, we discussed serotonin, and it is likely to be destructive. And apart from serotonin, 5-hydroxytryptamine and ACTH are also secreted. So we discussed all in all about carcinoid tumor and carcinoid syndrome, and we learned how the midgut carcinoids are more likely to produce carcinoid syndrome and more likely to metastasize. And now to wrap up this presentation, let's do a MCQ. A 51-year-old male presents to family physician. Over the past 6 months, he has had multiple episodes of non-bloody diarrhea. There is a flushing, and often wheezes is there. Often wheezes when he exerts himself. Past medical history is significant only for hypertension, which has been controlled with AC inhibitor. No history of smoking. Vital signs are temperature this and 98.7, and blood pressure of 121/81. And which of the following is the most likely diagnosis? So acute myocardial infarction, asthma, carcinoid syndrome, inflammatory bowel disease. So the answer is carcinoid syndrome, because here you are seeing the wheezing, non-bloody diarrhea, and all are there. So this is not the answer. Carcinoid just has been highlighted here, but the answer here, purposely I have highlighted it, but the answer here is carcinoid tumor. So don't get confused with this. This is a typical case of carcinoid syndrome. All wheezing, diarrhea, flushing, all these are the cases of carcinoid tumor. So this is typical of carcinoid syndrome. You will be given these kind of features. And that's all about carcinoid tumor. We discussed everything regarding clinical features, um, management, pathogenesis, and everything. And we discussed a Q&A for carcinoid as well. Now I will stop sharing the screen, and I will invite any kind of questions that you might have. If you have any kind of questions, then please feel free to ask me. Okay, in case of no questions from the participants, I would like to end the session over here. And thank you for attending. And you can again visit that, and feel free to ask me any kind of questions. And also you can directly contact me. You can be associated with me through various kind of a social media, through Instagram, um, through the YouTube, where we get lots of videos, and you can download our app, Pathology Simplified, as well, which we have lots of interactive study material, and some courses, free and paid courses are there. Thank you for attending the session. Bye bye and take care. I will see you next time very soon. Bye bye for now.